My name is Debra Johnston. I'm one of the clinical nurse specialists at Toronto General Hospitals for wound and ostomy. I'd like to welcome everyone to our next session this afternoon entitled Prevention of Pressure Injuries from Prone Positioning within the context of COVID-19 in an acute care setting. We'd like to thank Mölnlycke for sponsoring this session. Over the past decade, there's been a greater understanding of the mechanism of tissue damage associated with pressure injuries, and with this, a heightened awareness and responsibility in all care settings to prevent pressure injuries from occurring. As research evolves, innovative, patient-centered care for pressure injury prevention has been an integral part of both nursing and interprofessional practice. Critically ill patients cared for in an intensive care unit represent a unique subset of hospitalized patients, which are the sickest patients in our healthcare system. The development of a pressure injury represents additional comorbid threats to an already very compromised person. In addition to surgery, the use of prone positioning is rising sharply in intensive care units worldwide, where mechanically ventilated patients with acute respiratory distress syndrome secondary to COVID-19 are being placed in a prone position. Pressure injury prophylaxis for patients in a prone position and the projected consequences of the coronavirus pandemic make this present work more relevant than ever before. And next, I'd like to introduce our three presenters from St. Michael's Hospital in Toronto. First, Janeth Velandia, a nurse practitioner from the wound care program. Second, Noronha, an occupational therapist, also a member of the wound care team in the MS clinic. And third, Fionna Yau, the clinical nurse educator from the medical surgical ICU intensive care unit. For our attendees, please refer to the Wounds Care Canada app for a complete list of bios of all the speakers that you've seen today. And just a friendly reminder that during this presentation, please input any questions you may have for the speakers in a Zoom question and answer box. I'll do my best to collate the questions and pose as many as I can to the speakers at the end of the session. Now, I'll turn it over to Janeth.
Thanks, Debra, for the introduction. Good afternoon and welcome to our virtual talk. It seems that we are adjusting really well to our new normal using technology. Even here in the hospital, we are doing weekly virtual wounds rounds, virtual education, virtual wound consults, and look at us now in the 2020 Virtual Wounds Canada Conference. Before I start, I want to make a disclaimer. So any honorarium for this presentation will be donated to the St. Michael's Hospital Foundation. Today, we will be talking about prevention of pressure injuries from prone positioning within the context of COVID-19 in an acute care setting. We want to share our experience and how our team was able to translate best practice guidelines into a clinical practice in a timely manner in a challenging time due to the COVID-19 pandemic. I'm going to start with the background of our project, which started in July 2019. Pressure injury prevention and management remains a corporate level priority in Unity Health Network. In 2019, the medical and surgical intensive care unit and the wound care team started a project with the main goal to decrease the incidence of hospital-acquired pressure injuries in the MSICU. As part of this project, the plan was to collect pre and post data to show the effectiveness of the interventions. We completed chart audits to assess the compliance rate of braiding scale risk assessment completion and skin assessment documentation. We administered a survey to explore registered nurses' confidence towards pressure injuries assessment, staging, and management. We also completed a pressure injury point prevalence and incidence study. So the stage 1 of the project was successfully done by October 2019. The stage 2 of the project was related to strategies and interventions to decrease the hospital-acquired pressure injuries in the intensive care unit. We developed an e-learning module to assist with proper assessment, staging, and treatment. We also provided education to the nurses, and as well we updated the patient family education pamphlet related to pressure injury prevention. So the stage 2 of the project was successfully completed in January 2021. Stage 3, product evaluation. So we planned product evaluation using a soft silicone multi-layer foam to prevent sacral and heel pressure injuries. So prior to the product evaluation, we completed the following steps. So the first step was to do the literature review to assess the cost effectiveness of the product. We also reviewed the best practice guidelines, and we have the opportunity to meet in person with an expert clinician, Dr. Todd Brindle, who is currently the medical director of Mölnlycke Healthcare. He is also a wound care clinician at Medical College of Virginia. As I mentioned before, so we review the most current best practice guidelines. In this document, pressure injury prevention points, the NP-PHC recommended risk assessment, skincare, proper nutrition, repositioning, mobilization, and education. And under the repositioning and mobilization point, the NP-PHC also recommended the use of multi-layer foam dressing on the sacrum and heels on patients at high risk of developing pressure injuries. So what are the benefits of using the 5 multi-layer foam? So this foam has the ability to impact on 4 extrinsic factors that can contribute to the development of pressure injuries. So the foam helps minimizing and redistributing the shear forces. It helps as well by redistributing the pressure in the affected area. It helps as well by reducing the friction and maintaining an optimal microclimate. So in January 2020, we were ready to start the product evaluation. Unfortunately, in March 2020, the priorities changed. March 12, 2020, COVID-19 was declared a global pandemic by the World Health Organization. In the same month, in March, we were facing changes and challenges. We noticed an increase in the number of COVID-19 cases, hospitalizations per day. We noticed an increase in the number of patients being prone as part of the treatment in the intensive care unit. And as well, there was an increase in the number of referrals for patients with hospital-acquired pressure injuries secondary to prone positioning. Most of the pressure injuries and skin damage happen in over the face, in the forehead, in the chin, as well in the chest, hips, knees, heels, and the sacrum. So we have to change our plans due to the COVID-19 pandemic. So we have the advantage that by March 2020, we have created a team able to work together and ready for the challenge. The MSICU team and the wound care team were working together. So what we did as well, the team reviewed the current St. Michael's Hospital policy regarding proning positioning to make changes for patients with COVID-19. We also reviewed the most recent literature for prevention of pressure injuries from prone positioning. So now Fionna will talk about prone positioning for the treatment of acute respiratory distress syndrome in the ICU and our hospital policy. Fionna?
All right, thank you, Janeth. So just a little bit of background information. What is proning for those who don't know? Basically, proning is the process of turning a patient from their back onto the stomach, so they're lying face down, or I usually like to describe it as adult tummy time. So here is a picture of what a prone position looks like. This is one of our nurses who volunteered to act as our model. So just want to highlight in a prone position, some of the positioning devices that we use. If you notice underneath her head, her chest, her hip, and her shin are all supported with different types of pillows and repositioning devices. And these will make a little bit more sense, and we'll look into them a little bit more further throughout this presentation. So in the ICU, our patients are usually attached to different, IV medications. They're connected to the ventilator, all the life support machine, drains, dialysis. So getting into this position will require some coordination. Usually on average, it takes about 4 to 8 staff working in synchrony. That includes nurses, respiratory therapists, physicians, and it's done usually in a very slow, controlled, and coordinated manner to make sure that the lines aren't kinked, there's no tubes or catheters that are being tugged or accidentally pulled out, and the patient remains stable throughout the process. Now, the question of to prone or not to prone. To answer this question, it's best to start off looking at why do we prone. Now, there's many literature out there that suggests that proning improves oxygenation in patients with moderate to severe ARDS, or adult respiratory distress syndrome. And how that happens, the pathophysiology in layman term, is when you're turning a patient over, the lungs, extra fluid in the lungs gets shifted around, and so that offloads the pressure within the lungs, allowing the air sac, which is the part that does the oxygen exchange, to open up, allowing better ventilation and gas exchange. And so also with the change in position, you're mobilizing the secretion so it can be suctioned out of the patient a little easier. Now with COVID-19, the topic of proning has been getting more attention because COVID-19, as we all know, is a form of respiratory failure and in severe cases becomes ARDS. And there's more and more literature out there that looks at the benefit of proning to treat or as an intervention to manage COVID-19, which in our ICU in the last couple months has seen quite a bit. Now the question, when do we prone and is it for everyone? So this is more of a healthcare team discussion when we're considering the patient whether to prone or not. If they're thinking patient is an ARDS, they're also looking at other things like worsening respiratory symptoms, if there's increased oxygen requirement, changes in diagnostic imagings like X-rays or CTs, and also a very common clinical indicator that the physician use or the clinical team use is what we call a PF ratio. So using that formula, basically they're looking at the patient's oxygenation level from their lab value in relation to the amount of oxygen that they're receiving. And if this indicator is low or below 150, it's a prompt for clinicians to consider proning this patient. So now that we've decided to prone the patient, how long do we prone for, and what are some other nursing considerations? When a patient is proned, literature suggests that a minimum of 12 hours is required to see some form of benefits. In our practice, what we normally see is that patient gets proned between 16 to 20 hours. So if you can imagine, that's a very long time being on your belly, even for any, not even a patient, just you regularly lying in the same position for 16, 20 hours is quite long. So there's definitely other things to consider. It's not just a matter of turning the patient onto the belly and leave it as is. So before we prone a patient, there are a few other things that we should consider. The one thing being very important is the bed surface. So in order to prevent pressure injury, our hospital policy actually suggests us to use one of the 2 surfaces that are available. One being the specialty air mattresses, or the gel-based or a gel-based therapeutic pressure redistribution surface. So in that image there is one of the examples of a specialty air mattress, which is a more preferable. As you can note, if you notice those 2 elongated support, it is a air bolster that can be repositioned to support the bony prominences. However, with COVID-19, of course, those change things quite a bit. There's more infection control guidelines put in place, and so we weren't able to bring these air mattresses into the hospital because they deemed that we couldn't clean them appropriately with our current hospital supplies. And so the only option we were left was the gel-based therapeutic pressure mattresses. As it indicated, it's a gel-based, very simple therapeutic pressure air mattress that doesn't have these air bolsters. So what nurses have to do is being creative. So they'll use or make their own supporting devices or repositioning devices, such as using pillows, buckwheat rolls, rolled up flannel sometimes as a supporting device, which we know it's not ideal. However, we had to use what we had available at the time, which is one reason why we wanted to look into this project a little bit more, to look at what's out there, what's being offered, and what are some options that we can provide our patient. So beside bed services and repositioning device, another big key thing to consider is skin protection. So being in a prolonged prone position, there's always going to be areas on the body that's more susceptible to skin breakdown, and it's important that the nurses or the care team addresses these. So a few things that we also have to consider: the eye protection. When you're in a prone position, you're facing down. So there's eye patches, lubricants to protect the cornea. There's also later on, Janeth will show in her slides too, is the foam facial pillow that supports the head. But if you can imagine, a patient is facing downwards, so saliva gets drooled, and a lot of time it can cause maceration around the skin, around the cheek area. As well, when a patient is being intubated, meaning that they have a breathing tube sticking out of their mouth, the pressure point pushing against the lips can be a source of pressure injury as well. So on top of that, our hospital policy emphasizes to have looking at protective dressing. So what we normally use before COVID time is a clear, thin dressing that protects the skin against shearing. We're also considering things like minimizing linens underneath the patient and removing any medical equipment that could cause pressure injury. For example, ECG leads, which are typically in the front of the patient, now gets moved to the back. So this kind of leads us to look at what's out there in the literature that looks at prevention of these pressure injury from prone positioning. And what we came across is this National Pressure Injury Advisory Panel that created this really great and very helpful tip sheet that comments on what are some areas of consideration that we need to look at. So it mentions things like pressure redistribution surface, positioning devices, and to make sure that pressure points are being assessed routinely, and making sure that there's an appropriate intervention put in place to protect those areas, which are highlighted in this slide here on those green dots. The recommendation also emphasizes the looking at the skin integrity in the head, torso, legs, breast, and genitalia area. And so keeping all these recommendations in mind and these tips in mind, which kind of leads us to our project focus of looking at prophylactic foams, different positioning devices, and repositioning principles of how to best protect patient skin and optimize patient outcome. So I'll now pass it on to Janeth to talk about more about the prophylactic foams.
Thanks, Fiona. Well, so as mentioned before, the most affected areas during prone positioning include the forehead, the chin, the chest, hips, knees, the sacrum, and the bilateral heels. To prevent pressure injuries in the face, we decided to continue with the use of a foam pillow. This pillow provides a soft layer to equalize pressure on the face while safely supporting the head to prevent bottoming out. We also recommended the use of a non-sting skin barrier to be applied to bilateral labial commissure, that is the corner of the mouth, to prevent moisture-associated skin damage due to drooling. To prevent pressure injuries and skin damage in other pressure points, we recommended the use of a prophylactic multi-layer foam. So while in supine position, the nurses will apply a 13 by 16 centimeters oval shape multi-layer foam to the bilateral breast or to the chest. We also recommended the use of a 15 by 15 square shape to be applied in bilateral hips. Then we recommended the use of a 15 by 20 multi-layer foam to be applied in bilateral knees for protection. And then while in prone position, the nurses will apply the multi-layer foam to the sacrum and to the bilateral heels. And now, Lauren will talk about the use of positioning devices and repositioning principles. Lauren?
Thanks, Janet. And thank you for the introduction, Debra. So as Debra mentioned, I'm an occupational therapist who currently works on the wound care team with Janet. And as an OT working on the wound care team, once the pandemic hit, thoughts crossed my mind about what my role would be, considering that I was going to be redeployed to work within the critical care setting. So part of an OT's role normally in the acute care setting can be to prevent pressure injuries through offloading bony prominences and pressure points, among other things. So some typical devices used in all patients are things such as foam boots, heel lift boots to prevent heel pressure injuries from occurring, wedge pillows and positioning rolls, and that's all to ensure sufficient offloading of pressure points. But then hearing about the higher incidences of patients being in the prone position, as Fiona had explained earlier, made me think more about how pressure injuries are prevented in the anterior side of your body. So, and this is especially considering that, there were no specialty beds available to support these patients due to the pandemic. So my next step was to do a literature search, and I wanted to collect the best evidence around this. Okay, so to be honest, my search results weren't as robust as I thought they would be, but I was intrigued by what I found. So I won't go into detail about each paper listed here, but I wanted to make sure I summarized the main points that led us to the final product of this project. So as you can see, prone positioning was found to generate pressure injuries at a pretty steady rate. Preventative measures should be implemented at the same time when deciding to prone a patient. And another paper pointed out that it was vital to be successful, it is vital that the team collaborates. So all members of the team, the nursing staff, the respiratory therapist, clinical assistants, all have vital roles and responsibilities at different timings. And to no surprise, collaboration is the hallmark of team functioning. So it was very important and pointed out in these papers. And then again, we're back to the NP-IAP, which was pretty much the main set of best practice guidelines that really pushed us into developing the project even further. And it was a wonderful find for us. Okay, so now I had the NP-IAP document in hand, and the Faculty of Intensive Care Medicine guidelines were also very important, and that's out of the UK. And what they recommended was using pillows to offload various areas of the body while in the prone position. Now I'll explain the evidence behind the 3 areas of the body next. So you can see in the picture that there are pillows underneath the patient's chest. And this reasoning is to allow the breasts to be supported and free from pressure. Next, the pillows under the pelvis are to ensure the abdomen is free of compression And as you can see from the picture there, the patient's abdomen is completely free from compression. It's offloaded, there's nothing underneath it, which is the point of how these pillows are to be placed. And finally, you're not able to see this in the picture, but there are pillows across the patient's shins, and that is to prevent hyperextension at the ankles and to minimize pressure that's exerted on the patient's knees. So before I move on, a few important tips when positioning the pillows is that the pillow height should be altered to ensure the neck and lower back are not hyperextended. And it's really important for staff to keep the patient's size and height in mind to ensure the shoulders are a little bit slightly forward, so flexed a little bit. And that is to avoid the risk of brachial plexus injury in the arms and shoulders. And another thing to point out briefly is that this patient in this picture is in what is called a swimmer's position, where the position of the arms and the direction of the head are alternated in a manner that is similar to that of a freestyle swimmer. So here at St. Michael's Hospital, there can sometimes be a risk of that brachial plexus injury that I spoke about earlier. So some physicians prefer to leave both arms at the side, and that really depends on the medical team's preference. Okay, so now that I knew pillows were recommended based on the evidence, it was time to actually gather some feedback from the frontline staff, ICU nurses, clinical assistants, educators. So if you can read some of these quotes here, there are things like, pillows are not enough support for some patients, and without the specialty beds, it is so important to have a device that actually can support and offload patients. So we can see that best practice guidelines don't always translate very well into the frontline environment or into real life. So then I thought, what now? So we really had to do some problem solving and put our heads together. So what I ended up doing is going back to that original NP-IAP guideline document, which listed a more generic statement. And what it said was about positioning devices, that there are several devices available to support prone positioning in various materials and sizes. So the key here was to find a device that was able to redistribute pressure and reduce shear stress and strain. So here's where the Goldilocks reference came into play. Our team trialed various cushions and devices from around the hospital. We ordered some, some were too soft, some were not long enough, some didn't comply with infection control rules. Eventually, we agreed upon a bolster type, similar to one of these in the picture, and it seemed to be just right. So currently, we're using these devices as part of this particular project, and the work is ongoing. Okay, so as you heard earlier, another focus for this project was determining the repositioning principles to be applied within the context of COVID-19 in the acute care setting. So you may be aware of the term clustering care. And what that means is that the entire team within a patient's circle of care collaborates, and they determine what the care needs are and who will be able to reach those goals. And the whole point of clustering care is to avoid overexposure of many healthcare providers together seeing a patient at the same time. So keeping that in mind, typical repositioning in normal circumstances is to reposition every 2 hours. However, for patients with COVID-19 or suspected COVID-19 who are in the prone position, the principles change to include repositioning the head every 2 to 4 hours, and during the same time frame, making small adjustments to the body and to the arms. As I mentioned earlier, the arms may be in that swimmer's position, and so if the patient's in that position, the head and arms also need to be repositioned accordingly. So this is a summary of everything that we discussed about the project, and this slide shows we decided to make kits, and it's called a proning kit. And the idea of this is that we have a kit ready to use for each patient preparing to be proned, and we were hoping that it would simplify things for the ICU staff. So this example slide is an example of the education pamphlet that was created to be placed in like a plastic baggie together with the multi-layered foam dressings that Janeth spoke about. And our hope was to make things as easy as possible with very simple instructions and visual cues, especially for staff working in a high stress environment with critically ill patients. So these kits are currently being used for patients that are prone in the ICU here, which is very exciting because we finally saw our project come to life. So I'm going to pass it over back to Janeth to discuss a little bit more about the medical orders that was created as a result.
Thank you, Lauren. Okay, so our last step basically was working with the IT department to develop another set to facilitate and to standardize the medical orders related to the pressure injury prevention during prone positioning. These medical orders included the application of the multi-layer foam for 7 days. We specify the location. So the same like we explained it before. So the dressings are to be placed in bilateral chest, bilateral hips, bilateral knees, bilateral heels, and sacrum, not to be replaced. And this is a reminder that these dressings are used for prevention or for treatment at this point. So the second part of the medical orders, it is every shift, the skin assessment underneath the dressing with clear instructions. So we ask the nurses to first gently pull handling tabs until the skin is exposed, then perform an assessment and document if any skin damage, and then reapply the foam, press and smooth the dressing to ensure it is in contact with the skin. The third part of the medical order set talk about while in prone positioning, use pillows across the patient's chest, across the patient's pelvis, under patient's chins, check the pressure points and do head turn and eye care every 2 to 4 hours. And finally, while in supine position, turn and reposition the patient Q2 hours. So we came to the end. So these are our conclusions. So the prevention of hospital-acquired pressure injuries in critically ill patients remains a significant clinical challenge. Also, the COVID-19 pandemic has brought many changes and challenges, but also it has brought many opportunities to work with different teams to develop new protocols, ideas, and strategies to prevent hospital-acquired pressure injuries. Repositioning principles, use of multi-layer soft silicone foam dressing, the use of offloading devices, following best practice guidelines, plays an important role in the prevention of pressure injuries in the intensive care unit. We have come to the end of our presentation. Thank you so much for allowing us to share our experience in the clinical setting. If you have any questions, now we are open for questions.
That's wonderful. Thank you very much. I'd like to thank Janeth, Lauren, and Fiona for their very timely and informative presentation today. Depending on where you're virtually attending from today, some of us, including us here in Toronto, are experiencing our second wave of COVID-19. Healthcare providers around the world are struggling, I think, to keep up with demand of absorbing new knowledge during this very rapidly evolving pandemic, while still providing the best patient care that we can. Bundled approaches, such as the one you've created, make the very challenging task of implementing best evidence into best care look tremendously easy, but I know a lot of effort went into it. So congratulations to all of you. For our audience, please continue to put some questions into the question box, and I'll get to that as I can. I'll try to collate them as much as I can. Just thinking about the proning kit, I want to kind of go back to the proning and how we do that. I'm thinking about the pillows, the bolsters, the 5-layer foam dressings. A lot of questions have come in about how do you do that? So I wonder if you can help us just visualize how you would turn, how you would prone a patient that's sedated, that's ventilated. I think for some people that work in acute care and haven't seen that, it's sort of difficult to visualize. And I think it was Fionna that used the word synchronized, and it definitely is when you think about the amount of people that are in the room to make that happen effortlessly. Could one of you maybe walk us through, just so our audience can visualize how you would turn that patient onto their abdomens?
Sure. I can kind of share our experience that we use in our facility. So like I was mentioning in the presentation itself, synchronized effort by the RT, MD, nurse, as well as our clinical assistant as well. So we usually have our physician there, who's kind of like the lead and in charge, very hands-on, but he's there pretty much to direct and instruct the rest of the mini teams that are being responsible for different areas. So the nurse will likely be in charge of someone managing the line. Usually there's going to be IV lines hanging up either from the neck or from the groin. The RT there usually is 1 or 2 of them at the head of the bed, coordinating together, somebody holding the ETT tube as we're doing the turn itself. The clinical assistants and the other nurses or physicians that are there will more like the manpower to actually doing the physical movement, while the other nurses, like again, physician, nurse, and the RT are managing the rest of the line. So at the end of the bed, that's where the physician usually positions himself, and he will call out and synchronize the entire team and say, on the count of 3, we're now going to shift the patient over to their side. Pause, make sure everything is not tugged, everything is all aligned, patient is stable, and then again, another synchronized move on the count of 3 to shift the patient to one end of the bed. Pause there again, make sure everything is aligned before we then put him on, he or she, on the stomach or in the prone position. And even at the end of being prone, we'll also do a final checkup, make sure all the lines are not kinked, nothing is pinching onto the patient's skin, patient's stable, and the position is where the whole entire team is happy about, because as Lauren was mentioning, that the repositioning does require a lot of effort, coordination, and it's done every 2 hours. So we don't want to put patients at risk of any pressure injury while we put them in that prone position. So always checking sure that there's nothing underneath the skin, nothing is putting pressure on the skin, and that patient is stable as well.
Wonderful. I think it does. So before the patient is turned, then your pillows, your bolsters are on top of them. So as you're being turned, they're just rolling over on top of those. You're not trying to put those in afterwards.
So depending on the mattresses that we have, like I mentioned, there's the air mattress and there's the gel mattress as well. If it's the air mattress, it's actually designed to do proning. So what it does is that the air bolster, it's actually already underneath the patient as they're being turned. And once they're in the right position, it gets inflated, and then we adjust the height of it. So that's makes it a little easier for the staff. In cases when we're using the gel therapeutic surface, ideally if a patient is a little bit more, how should I say this, regular size, a little bit more manageable, then we can turn them directly over the repositioning device, the pillows or the bolsters that we use. However, sometimes we do struggle a little bit because if there's a lot of lines that it's harder to coordinate that, we might turn them in the prone position first and then lift the patient up to put the bolster pillows underneath.
Wonderful. Thank you. We have a question from Ella, who wants to know if the foam dressings are applied to prevent pressure injuries.
So the foam, I'm going to address this question. So the foam dressing can be used for prevention and for treatment. So in this case, in our protocol, it was strictly a prophylactic dressing to prevent pressure injuries.
Wonderful. A question from Anne-Marie that said, she'd like to know how many patients underwent the proning pressure injury protocol, and did you have a reduction in the COVID-19 prone patient pressure injuries?
So I think that we used the protocol in around 8 patients, and I think that we were able to prevent pressure injuries in the face, in the chest, in the hips, in the heels. I think that 1 or 2 patients developed a pressure injury in the sacrum, and the main challenge actually was the knees. Because the patient, as Fiona mentioned, they stay in the prone position for about 12 hours. And the original dressing that we used was a square shape, 15 by 15, that it was, the edges were rolling every time that they turned the patient. So at the end, we decided to change the size of the dressing. We use a rectangular shape that worked better. However, a few of the patients, they develop pressure injuries in the knees.
I guess that's a very difficult anatomical position because there's not a whole lot of subcutaneous fat there, so it's very difficult to protect.
And I think that what we learned this morning, there was a really good talk in the morning that says these patients are critically ill. We know that the vascular system is already affected, so there is a skin damage just because of the physiopathology of the COVID-19. So what we're trying to do is to prevent further skin damage.
Wonderful. We do have a shout out here from Cecilia. She says, thank you very much for the great presentation. She also wanted to recognize and shout out to the efforts made by Geeta, the APCEs and ICU team at Unity Health St. Joseph, I guess that's your sister hospital, and preventing their pressure injuries too during proning. So congrats to all of you for all these wonderful protocols that you've made. There is a question here from Cindy that wanted to know if there was any contraindications for proning patients.
Yeah, absolutely. We want to prone everybody if they do meet the criteria. However, there's definitely some contraindications. So right off the top of the head, I can think of is if a patient has an open abdomen or open chest, we can't prone them. Also, if their intracranial pressure is too high or uncontrolled, we also can't prone those patients. Pregnant patients, or thinking also ortho patients who have these hip external fixators that won't allow them to lie on their belly, and any spinal instability as well. So those patients won't be able to be proned, as well as just in general, if they're hemodynamically unstable, like I mentioned before, it does require a lot of coordination to get a patient proned and unproned. So if a patient is unstable, we chose not to prone them because they're at higher chance of either pre-arresting or arresting, and we probably won't be able to get them back in a supine position to provide ACLS care as early as we want to be. So.
Right. Another question about the proning positions. If there's modifications that can be used for those patients that maybe have a neck or shoulder restriction, like frozen shoulders or patients with arthritis, is there any different modifications that you would use for those patients?
I guess Lauren did kind of mentioned in her part of the presentation, in our policy, we kind of suggest something called a swimmer position. So your patient, I have to show you guys how it looks. So
you can show
one
us,
arm
that's
up
okay.
and one arm down like so, and the patient will be facing the arm that is supposed up. If the patient has like a frozen shoulder or arthritis that won't allow them to get into that position, we have something called a kind of Superman, but like two Superman with the arms on the side. So we don't put them in the swimming position and just kind of keep their shoulder neutral.
Okay. I guess along that line, just when you're talking about turning the head, there's a question about stabilizing, securing the ET tube. How do you do that? And do you reposition it to prevent medical device related pressure injuries?
Absolutely. That's what our RT team is there for when we do any kind of proning or even during the repositioning. They're also going to be there inside the room to help out with the ETT repositioning piece. In terms of how to secure it, we have something called an anchor fast. So it's a device that holds the ETT tube in place, and it allows the RT, when they're moving the ETT tube, to shift it from left to right. So if they're facing, let's say, one side, they will offload it so it's not pinching on or pressuring on that side of the lip. And then when turn over to the other side in the every 2 to 3 hour turn, they reposition the ETT tube to the other side.
Wonderful. So this is a question just about the use of the multi-layered foam dressings. And just to confirm that you are changing it every 7 days when it's for prophylaxis.
Yes, so for prevention, and that's part of our medical order set, so we ask the nurses to keep the same dressing in place for 7 days. However, we recommend every shift skin assessments. So they just lift the dressing, assess the skin, and just put it back and document if there is any skin damage.
Christine had a question just about that, Lauren, about how do you assess the skin on the preventative dressing when the patient is prone? Do you wait until they're turned over and then do your skin assessment?
That's a good question.
Yeah.
Sorry, go ahead, Janet. I think so. You try to do your best when they're in prone to kind of peel back the dressing if you can, reach the area, or you do wait after the 12 hours or so that they're back in supine position to check that. And correct me if I'm wrong, Janet, I think that's what the nurses have been doing with our instruction.
Yes, so when they are in prone position, they are going to assess the skin of the sacrum and the heels, and then they try to do the best to assess the hips, just making sure that the dressings are still in place, and the same with the knees. And then when they turn, that's when they do the skin assessment. It is important as well to understand that these patients are so unstable. That's like we cannot turn them on a regular basis. They are connected, they have multiple tubes, and as well they are on dialysis units, so it's really challenging.
Going back to one thing that Lauren had said about best practice guidelines not always being translatable at the bedside, I think this is so true. One challenge is proning patients with a higher BMI. Do you have any strategies around that? And offloading those bony prominences.
That was a big challenge with this project because finding the right device that would actually support patients and completely offload them was a challenge, and asking the frontline staff, going to them and saying, like, look at this device, do you think this would work? That was one of the things that we had to just kind of problem solve around. So I know manpower when it's a patient with a higher BMI is really important, having the right amount of people so that no one gets injured and that patient is kept safe the whole time. And using maybe more than one offloading device and positioning it in a strategic way so that we can try to support the patient's body in that way. It's never going to be perfect, but you try to problem solve and use whatever devices you can in order to make sure that we can prevent pressure injuries the best way that we can, as well as moving. There's a lot of medical lines, the tubes, everything, trying to get that out of the way before. So the preparation part is very important here, as you can imagine.
Yeah, I like what you said about it being back there. I like what you said about feeling like Goldilocks, and how one thing was too soft, another pressure device might have been a little bit too hard, and how you're just going back and forth to that drawing board trying to find the right thing, especially in this climate with limited resources. We don't always have the right things at our fingertips in the moment. So how did you and your team determine what was the best offloading? How were you assessing those bony prominences to make sure they weren't bottoming out on the surfaces?
Absolutely, it was very much like that. We started with knowing that pillows, like I said, were the best and were the recommended guidelines. But the minute we spoke to clinical assistants, nurses, everyone's first reaction was like, that's not going to support my patient. Like they're gonna squish the pillow and then that's it. So we tried to use different devices that we could find. We actually started with, I think it was a bed extender, just to have the right shape. So we just said, let's try this, see if this type of shape and the length of it works. And then from there, if that was used and kind of better than a pillow for that patient, we went to, and Fiona was big in this, looking for devices that were out there to order in order to trial them. So it's kind of still in progress, to be honest. We're still receiving the devices and trying them out.
Yeah, I think it is. It's just that back and forth. So yeah, there is a question about how the effectiveness of the interventions are being measured. Do you have any ways that you're measuring the effectiveness of the different strategies?
So at this point, we are measuring, like based on the amount of referrals that we get with patients with new hospital-acquired pressure injuries, as well with the severity of the pressure injuries. And that's something that we are trying to figure out for the second wave. So we are trying to get ready to be able to collect data now that we have the protocol, because the initial part was not a clinical study. It was the implementation of a protocol to prevent pressure injuries. So now we want as well to do some data collection.
Yeah, it's very, it's just very fortuitous that in 2019, you had this collaborative effort with the wound care team and ICU team to prevent pressure injuries, kind of in a more general place. And then with COVID, March 12th came, and now we're looking at specifically proning pressure injuries, but you already had everything in place. You've educated your staff, you've done knowledge surveys, pre and post, your education, your patient pamphlets. You're in a great place. So I have a question from Anne Marie about as you're preparing for the second wave, are you doing anything differently?
Well, I guess as I mentioned before, so now I think that we are ready with the kits. So we have been able to assemble the kits. So it is a kind of plastic bag with the different dressings and the instructions so the nurses can get the supplies. Fiona and Lauren are working in the acquiring the pillows or the proper offloading devices. And now we are trying to, so we standardize the protocol and we want to collect data. That's what we want to do for the second wave.
Wonderful, and hopefully publish so we all learn worldwide what works. I have two kind of housekeeping questions that have come through. JF would like to know if your protocols are available for sharing. And if they are, could you tell maybe other attendees who may be wanting the same thing where they could find them?
I can look into that. I know we have it on our hospital's internet site. I don't know if it's out for public, but I can definitely look into that and get back to you and share it with everybody.
Okay, and this next one might be a question for Maureen. They're just wondering if the presentation, the PowerPoint, is available for downloading. And I don't know the answer to that.
Usually that's up to the speaker because the presentation is deemed intellectual property. So that would be up to the panel to provide a link somewhere, an email, something of that nature, and they would need to send it direct.
Okay. I guess if you did have questions for the individual speakers today, whether it's Fiona or Janeth or Lauren, their email addresses and their contact information are listed under the speaker bios under the Wounds Canada app. So you can always go there for more contact information. I do have a question from Marcy, and she says, when you're looking at support materials, did you consider using the U-shaped breastfeeding pillows? I've looked at the shape of these. Sorry, I don't have my glasses. I've looked at the shape and ease of placement prior to COVID-19. I felt that prone position would be a great option for offloading these pressure sites.
I remember that we did actually bring that up as a potential solution for supporting patients. I think we had a difficult time finding one that would be able to be cleaned. So, you know, the infection control policies were huge in this as well because we had to have the right material. So we did want to try that, but we just couldn't find one to use with that shape.
Okay, lots of other comments coming in saying great teamwork. They're liking what you're doing. Is there a problem with ECMO? Is there a challenge with ECMO sites that are active and in use? Cecilia.
I can't really comment on the ECMO piece because from the first wave, most of our ECMO patients were sent to a different hospital to get the ECMO treatment. But me trying to think if we did have a ECMO patient, I don't think that would be a problem because I understand that ECMO lines will be in the femoral veins, and that's usually where our dialysis catheters are as well, and we can still safely prone patients while on dialysis. The only problem or trouble that we might run into is the pressure. If it's a fairly larger patient, if their abdomen is compressing on the catheter itself, is it going to affect the effectiveness of the ECMO? That I'm not too sure because we didn't have a patient on, but I'm just thinking from experience, though, for patients who were on dialysis, having a line in the groin, the dialysis line in the groin, we didn't have any problems with that.
Wonderful. And then another one from Anne-Marie. Could you use the heel multi-layer dressing on the knee? So I guess thinking back to the comment that maybe Janeth had made about needing a larger size, the rectangular one for the knee. Anne-Marie is wondering if you could use the heel multi-layer dressing on the knee.
I think that we can try that. Actually, that's a really good suggestion. What we found that the dressing that stay in place most of the time are the sacrum and the heels because they have the shape, anatomical shape.
Yeah.
But I guess that's a really good suggestion because that has been the issue with the knees.
Cheryl has a question. Have you had patients with dementia? And if so, what has been your experience?
For prone, usually I would say 99% of our patients who are prone are severely sick, and again, usually in ARDS, so they're intubated, sedated, and sometimes even paralyzed. So it's really challenging to assess the dementia piece when the patient is fully sedated and fully paralyzed. So kind of hard to comment on that. Usually by the time they're well enough, they're usually back in a supine position, extubated, or awake. Then we can do the assessment of the dementia piece. But right now, we don't have experience with that.
Okay. Cecilia would like to know, could you comment on microclimate management of these patients? So I would imagine in terms of managing the moisture, definitely the 5-layer dressings help to wick and absorb some of that moisture from the dependent areas. I'm thinking probably most of these patients have a Foley catheter, fecal management system, some on airbed.
Okay, so microclimate basically is the amount of moisture. With these type of patients, we are using the low air loss mattress, which is going to bring as well that help to manage the microclimate. But regarding the foam dressing, so what we find is that it is really absorbent and as well decrease the moisture associated skin damage and kind of protect the skin for deterioration. So I think that is the microclimates is regarding the dressing, the bed that we use, and as well the repositioning. For incontinence, if Fiona can help me, but I think that most of the patients, they have a Foley catheter, and I don't know if they have a rectal catheter as well.
If needed, then they will have it as well.
I hate to wrap this up because it's been so great. The questions are continuing to come in, but unfortunately we have to sign off. Our time has come to an end. So in closing, I'd like to thank Janeth, Lauren, and Fiona again, as well as Mölnlycke for sponsoring their presentation. I think your presentation highlights the benefits and the strengths of interprofessional collaboration and communication. I think professions have always worked closely together, but now we have such a deeper understanding for what each of us can contribute to a patient's situation. We're all needed and we're all in this together. As a couple of reminders for our attendees, please visit the sponsor booth and the sponsor chat room with Mölnlycke. At the end of the session, evaluation link will appear in your chat box. Please copy and paste that link into your browser and take the time to complete the session evaluation for today. Thank you very much.